Good evening, everyone. And first of all, at the outset, I would like to thank the organizers for organizing such a wonderful event, as always. And also thank you for giving me this opportunity for presenting this data. In the next five abstracts, we are going to discuss data regarding the Mona Lisa trials, that is, use of ribociclib along with endocrine therapy. So the first abstract is regarding the overall survival results from the phase 3 Mona Lisa 2 trial of postmenopausal patients with hormone positive advanced breast cancers treated with endocrine therapy with or without ribociclib. So this was presented in ESMO 2021. We know that the phase 3 Mona Lisa 2 trial investigated ribociclib plus letrozole in the first line setting in postmenopausal patients with hormone positive advanced breast cancers, and a significant PFS benefit was reported with ribociclib plus letrozole. The median PFS was 25.3 months versus 16 months, and even the phase 3 trials, that is Mona Lisa 7 and Mona Lisa 3, both have demonstrated a statistically significant OS benefit with the addition of ribociclib. But here in this trial or data, they have reported the final OS analysis from the Mona Lisa 2 study design. This is the Mona Lisa 2 study design. We know that the postmenopausal females with hormone positive, HER2 negative advanced breast cancers were randomized in a 1:1 design to receive either ribociclib plus letrozole versus only letrozole. The primary endpoint was PFS, the secondary endpoints were OS. And this is the baseline patient data, and we can see that the median duration of follow-up was almost 80 months, that is around 6.5 years, which is really robust. And what is interesting to see is that almost 9% of patients who received ribociclib plus letrozole were continuing the treatment even at the end of 6.5 years. And as expected, we can see here that the curves are widely separating, and we can see that the median OS with the combination of ribociclib plus letrozole was around 64 months versus 51.4 months with letrozole alone. So almost a 12.5 months OS benefit was achieved with ribociclib plus letrozole, which is really significant, with a p-value of 0.004. And what is more interesting is to see that the OS benefit with ribociclib increased over time. So at 6 years, we can see that the percentage of patients surviving with the combination of ribociclib and letrozole was 44.2 months, 2% versus 32%. That is almost a 12.2% increase in the survival rate with the use of combination of ribociclib plus letrozole. And this OS benefit was consistently seen across all the subgroups, irrespective of the age and the use of prior chemotherapy or hormonal therapy. And we can see that the patients who received this placebo where subsequently almost 34.4% of these patients subsequently received some sort of second-line CDK4/6 inhibitors. But even after that, this OS benefit was consistently seen. And so effectively, ribociclib delayed the time to first chemotherapy by almost a year. We can see that the median time to first chemotherapy was 50.6 months in the combination versus 38.9 months. And overall, as such, no new safety signals were identified even at the follow-up of around 6.5 years. Whatever events occurred were most commonly seen in the first 12 months of the treatment. And the rates of grade 3 or 4 adverse events of special interest were almost the same, which were already been reported. So this study concluded that a first-line ribociclib plus letrozole demonstrated a statistically significant and clinically meaningful OS benefit compared to letrozole alone. We can have a prolongation in the OS to the tune of over 12 months. And overall, we don't see any new safety signals even with the prolonged use of ribociclib with an follow-up of 6.5 years. And so ribociclib combined with endocrine therapy is the only first-line treatment with an OS benefit, and therefore it is proposed that it should be considered as a preferred treatment option for first-line hormone-positive advanced breast cancers. Coming to the second abstract, in continuation with the first one, this is regarding the overall survival subgroup analysis by metastatic site from the phase 3 Mona Lisa 2 study. This was presented in SABCS 2021. So we have already seen that Mona Lisa 2 has reported a statistically significant OS benefit with the first-line use of ribociclib and letrozole. And here they have presented an exploratory OS analysis of patients in Mona Lisa 2 study in subgroups by location of metastasis, number of the metastatic sites, and the use of prior therapy. So this we have already seen in the first abstract that we can achieve a prolongation in the overall survival by almost a year with the use of the combination of letrozole and ribociclib. And now if we see by subset analysis, especially in patients with bone-only metastasis, we can see that the curves are widely separating. The median OS is around 72.6 months with the combination of ribociclib and letrozole, that is almost 6 years, as compared to letrozole alone, where the median OS is 56.4 months. So the ribociclib in combination with letrozole has a OS benefit in patients with bone-only metastasis as well. If we see patients with liver metastasis, numerically the median OS is almost the same, 37.7 versus 38 months. But if we see that the graphs are separating at the end of 5 years and 6 years, so the OS benefit is persistently seen at 5 and 6 years in patients even with the liver metastasis. If a combined subgroup of liver or lung metastasis is seen, again we can see that the patients that the OS benefit with ribociclib in addition to letrozole is seen at the end of 5 years and even at the end of 6 years. Now coming to the number of metastatic sites, we can see here that in both the subgroups, even in patients who were oligometastatic as well as in patients who were having metastasis more than or equal to 3, the OS benefit was consistent, though the magnitude of benefit was more pronounced in patients with oligometastatic, that is less than 3. We can see that the median OS improvement was almost by around 12 months, that is 68 months with the combination versus 56 months with letrozole alone. So overall, in both the subsets, the OS benefit was consistent with the use of ribociclib. And this benefit was also seen irrespective of the prior use of chemotherapy. We can see here that the curves are separating, and same was the case with the prior use of endocrine therapy. So OS benefit was consistently seen across all the subset. So to conclude, this study showed that whatever improvement in the overall survival was seen with the use of ribociclib and letrozole as compared to letrozole alone was independent of the metastatic sites or the number of metastases or prior use of chemotherapy or endocrine therapy. So overall, this consistent improvement was seen in long term, that is even at the 5 and 6 years of use of ribociclib. Coming to the third abstract, this is regarding updated overall survival results from the phase 3 Mona Lisa 3 trial of postmenopausal patients with the use of ribociclib plus fulvestrant. This was presented in ASCO 2021. Now, we have already seen that Mona Lisa 3 trial evaluated the combination of ribociclib plus fulvestrant in postmenopausal females with hormone-positive advanced breast cancers, and it has already shown that there is a significant PFS and OS benefit over fulvestrant alone. But in the final protocol, which had a median follow-up of 40 months only, the median OS was still not reached. So here in this abstract or in this study, they have reported an exploratory update of OS with a longer follow-up. So the follow-up here is about 56.3 months. This is the study design of Mona Lisa 3. Men and postmenopausal women with hormone-positive advanced breast cancers were randomized in a 2:1 design to receive either ribociclib plus fulvestrant versus only fulvestrant, and the primary endpoints were PFS, and the secondary endpoints were OS, response rates, clinical benefit rates, and etc. These are the patient characteristics. We can see that both the arms were fairly well matched, and again, as expected, we can see that the overall survival was significantly better with the addition of ribociclib to fulvestrant versus fulvestrant alone. The median OS was 53.7 months versus 41.5 months with fulvestrant alone. There is almost 12 months improvement in the overall survival with the combination. So even with an extended follow-up of 4 years and even at the end of 5 years, what we can see, the graphs continue to separate and the OS benefit is seen to be meaningful even in the long follow-up. Again, in terms of line of setting of use of this combination, in first line setting, this median overall survival is still not reached with the combination of ribociclib and fulvestrant. And we can see that even in the second line setting, if we use this combination, the overall survival is still better with the use of combination. The median OS improvement with the use of ribociclib plus fulvestrant is to the tune of 6 months. So we can achieve a 6 months longer OS with the use of combination versus fulvestrant alone. Again, this benefit in overall survival was consistent across all the subgroups. This is what we can see from this forest plot. And what is more important to see is about this subset, that is endocrine resistant population. We are always concerned about the use of subsequent endocrine therapy or hormonal therapy in patients, especially in those who are endocrine resistant, because we know that those patients may not respond well to the hormonal therapy. But if we see in this subset analysis, we can see that the combination of ribociclib and fulvestrant actually improved the overall survival as compared to fulvestrant alone. The median overall survival was 34.6 months versus 31.7 months, so almost a 4 months improvement in the overall survival was also reported even in this subset of endocrine resistant population. So effectively, the time to first use of chemotherapy was significantly prolonged by the use of ribociclib or addition of ribociclib. We can see that nearly 20 months delay to the use of first chemotherapy can be achieved, and so effectively we can give a more prolonged chemotherapy free survival to our patients to the tune of around 10 months. Again, that also translates to the PFS2, which is significantly improved with the use of ribociclib in addition to fulvestrant. And again, as we have seen in previous study designs, almost 30% of the patients in the fulvestrant arm subsequently received some sort of CDK4/6 inhibitors. But despite this, we can see that the OS is consistently better with the use of ribociclib in addition to fulvestrant. And no new safety signals of special interest were observed even with the longer follow-up. Whatever we have seen was consistent with the prior data. So overall, this study concluded that even in this exploratory analysis of an extended follow-up of 56.3 months, ribociclib and fulvestrant maintained the OS benefit in postmenopausal females, and this benefit was consistent across most of the patient subgroups and settings. And so Mona Lisa 3 remains the only randomized trial evaluating CDK4/6 inhibitors and to demonstrate an OS benefit in this postmenopausal hormone positive patients in the first line setting. And overall, with this use of combination, we can achieve a subsequent delay in the use of chemotherapy and give a more prolonged chemotherapy free survival to our patients. And there were no significant new safety signals which are observed even with a longer follow. Coming to the fourth abstract, and in this abstract, we are seeing overall survival results by age subgroup. So, especially in the Mona Lisa 7 trial, where this combination of endocrine therapy for ribociclib was evaluated in the premenopausal patients with hormone positive advanced breast cancers. It was presented in the ESMO Breast Cancer Virtual Congress. And we know that the phase 3 Mona Lisa trial, in that trial, it was the first trial which was dedicated for evaluating the use of CDK4/6 inhibitors in the pre or perimenopausal females who are having hormone positive, HER2 negative advanced breast cancers. And this trial has already shown that there is a significant PFS and OS benefit, as well as there is an improvement in the quality of life if we add ribociclib to the endocrine therapy versus endocrine therapy alone. Now, also in that exploratory analysis, with a median follow-up of about 53.5 months, it has also demonstrated that the OS is also significantly prolonged with the addition of ribociclib. However, we know that the younger patients generally have a worse prognosis as compared to older patients. So that was the main objective of this analysis, and it was evaluated to see the impact of age, especially with the patients who are less than 40 years versus more than 40 years, and to evaluate the efficacy and safety of the combination, that is ribociclib with endocrine therapy versus endocrine therapy alone in the patient population of Mona Lisa 7. These are the baseline characteristics. We can see that the characteristics are fairly well matched in both the subgroups, that is patients less than 40 years as well as patients more than 40 years. And what we can see here is that even in patients who are younger, that is less than 40 years, we can see that the graphs are separating very nicely, and there is a statistically significant improvement in the overall survival with the addition of ribociclib to the endocrine therapy. The median overall survival was for 51.3 months versus 40.5 months with the addition of ribociclib. That is almost improvement of 11 months with the use of this combination. And also there is a reduction in the risk of death by 35%. So we can see that at the end of 4 years, there is almost like 15 to 20% improvement in the 22% improvement in the overall survival with the addition of ribociclib, even in this patient population of less than 40 years. Similarly, even in patients with more than 40 years, the overall survival is improved by almost 6 months, and the relative risk reduction in the risk of death was almost to the tune of 20%. So effectively, the progression-free survival too was also prolonged in patients with both this subset, that is less than 40 years as well as more than 40 years. And this effectively translates into delaying the time to first chemotherapy, as well as the chemotherapy-free survival, which is provided by the combination of ribociclib plus endocrine therapy in both these population subsets. As seen earlier also, the patient who received only endocrine therapy, almost 27.5% of this population effectively received some sort of second line CDK4/6 inhibitors. And even after that, we can see whatever OS benefit we have seen was consistent with the combination of ribociclib plus endocrine therapy. And effectively, no new side effects or effects of safety concern were observed with the use of this combination, even with the prolonged follow-up. So this concluded, or this exploratory analysis of Mona Lisa 7 trial, with an extended follow-up of about 53.5 months, concluded that ribociclib with endocrine therapy prolongs the overall survival and improves the post-progression outcomes in both pre and perimenopausal females. And especially point 2 we noted is that This effect is more pronounced in patients with less than 40 years, which we all know that they all have worse prognosis as compared to the older population. So what we can say is that now we have a robust data to show that the addition of the CDK4/6 inhibitors with the endocrine therapy gives more prolonged overall survival to the patients, especially younger than 40 years of age. Coming to the last abstract, this is interesting, and it is about correlative biomarker analysis of intrinsic subtypes across the Mona Lisa phase 3 studies. So this was presented in Journal of Clinical Oncology 2021. We know that there are different intrinsic subtypes of breast cancer based on the gene expression profiles. And at this point of time, we don't know the prognostic and predictive value of these intrinsic subtypes with the combination of ribociclib and endocrine therapy. So this trial was evaluated to see the effect of this intrinsic subtypes on the PFS. So it was a retrospective exploratory PAN50 based analysis of the tumor samples from the phase 3 Mona Lisa trials. And the prognostic relationships were evaluated based on the multivariable Cox proportional hazard models. So effectively around to the tune of 1,160 tumors were robustly profiled, and around 46% were luminal A, 24% were luminal B, 14% were normal like, 12% were HER2 enriched, and 2.6% were around basal like. And they found that there is an association between the subtypes and the PFS, which was statistically significant. This is the multivariable Cox analysis, which we can see. And in the ribociclib arm, we can see that the hazard ratio adjusted is 5.29, which goes to say that the effect of ribociclib is less expressed in basal type tumors. Also, in this charts, we can see the orange chart belongs to the basal type. And we can see that even in the ribociclib as well as the placebo, the effect or the benefit of ribociclib is least pronounced or worst. And if we see the individual subsets, we can see both in luminal A and luminal B, the charts are widely separating with the use of ribociclib versus placebo. And same is the case with HER2 enriched as well as normal like. But if we see in the center, patients with basal like tumors do not derive benefit with the addition of ribociclib. The charts are overlapping. Hazard ratio is 1.15. So overall, the conclusion of this analysis was that the effect of ribociclib with PFS is pronounced in each of the intrinsic subtype except for the basal like. So that goes on to say that hormone positive breast cancers are a heterogeneous biological disease with different prognosis and treatment, and that highlights the importance of tissue sampling in the larger randomized trial. So what all we want is to provide our patients best possible outcomes. So maybe with this data in future, we may be sampling or maybe doing the profile of our patients before we select the hormonal therapy. That is to give our patients the best possible outcomes. So that's all from my side. Thank you very much.